Welcome to the breakout session, Money Matters, Tackling Finances During Brain Tumor Treatment. Managing the financial impact of a brain tumor diagnosis can be overwhelming. This session will provide practical guidance on understanding the cost of care, exploring insurance and assistance options such as Social Security and disability, and building financial literacy to make informed decisions. You will gain strategies to navigate medical expenses, plan for long-term needs, and access resources that can help ease the financial burden of treatment. Aimee Hoch, who is a master's level social worker with 20 plus years of experience in both healthcare and behavioral health. Her practice is focused on oncology, specifically addressing financial toxicity. Aimee is an integral member of the Oncology Financial Advocacy Team at St. Louis Grandview Campus, formerly Grandview Health, where she created and launched the Financial Navigation Program in 2018. Nationally, she serves as the Financial Navigation Specialist for the Cancer Support Community Helpline and frequently speaks on the topics of financial toxicity and financial navigation in cancer care. Please welcome Aimee.
Lower this a little. Hello, everyone. Thank you so much for being here. I'm so happy to be here at this conference. Hello to everyone here in the room and everyone online. Thank you. I applaud ABTA for pulling this conversation as part of the conference. It's such an important piece of your treatment plan and treatment care. And without addressing this, we often can't access the treatment that we need. So very happy to be here. These are my disclosures. So we're going to start by understanding this word financial toxicity. When I started working in this field, this is I learned of this term. And generally, it's the financial strain that an individual and their family and caregivers face when looking at cost of treatment and cost of care. It's also referred to as financial hardship, and you'll also hear the word financial distress. We use it very often in healthcare now. It's been well researched. We'll talk about a little bit of that, but it's a very common term that you'll hear. So the factors impacting financial toxicity, we know that new and expensive treatment combined with improved survival and longer treatment duration impact spending. Individuals on oral therapy are particularly vulnerable to high out-of-pocket costs. When you couple this with non-medical costs such as loss of income, often other life events and life changes, or having a fixed income upon diagnosis, this impacts that level of financial toxicity that an individual experiences. But it goes beyond the cost of treatment. There are other factors that impact the level of financial toxicity that somebody faces. Their type of insurance and coverage, what their out-of-pocket costs, that varies for everyone, bills, the prior authorization process, denials, all very stressful and impact that distress that someone feels. Having multiple appointments, going to radiation, the doctor's office, having scans scheduled, so all of those co-pays at multiple appointments factor in to this. Often having reduced work hours or loss of employment and income is another area that really impacts the distress that somebody experiences. Being on a fixed income, even prior to diagnosis, if somebody's already retired and has their Social Security, we need to consider that as well when we first start working with an individual. And other considerations prior to treatment. Maybe there was financial strain prior to diagnosis. There's often an increase in daily living costs. Just being out of the home at multiple appointments, food costs, different things that come along with that. Your geographic location can impact financial toxicity. And of course, travel costs. There are many more. The impact on caregivers that are often taking time off of work. So there's other factors beyond the treatment costs that impact that level of distress. It often forces someone to face making decisions about paying for treatment, paying for other things. And often people start making sacrifices and are focused on, skipping appointments or choosing what to pay for at that moment. This is a study that looked at that financial sacrifice, and they found that 49% were willing to declare bankruptcy, 38% were willing to sell their home, and 65% were willing to make other sacrifices, including borrowing money for their care. We know that financial toxicity impacts quality of life, and this is a study they worked with a group of those diagnosed with primary brain tumor, and in this study they found that financial toxicity was associated with higher anxiety and lower quality of life. And their recommendations were early screening and access to personalized support. I'm going to go through a lot of different topics about insurance and resources, and it really is very individualized. So we'll cover things broadly, but everyone's situation, insurance, their life situation, and the resources we put in place are very, very individualized. This is another study I like to share because it just talks about the scope of financial toxicity and financial distress. And in a way, unfortunately, this is something that is common, but it also helps normalize the situation and know that there are many others going through this and that we have services and resources available to help. So this study found that 74% of those that they surveyed reported financial distress on a scale of 5 or above, on a scale of 1 to 10. What's staggering is that only 40% of those individuals utilized resources and found help with either financial counseling or financial assistance. So we really need to do better at letting people know there are, people in their treatment centers like me or national organizations that can help with this. By doing that, we really need to start that cost of conversation very early on. You'll hear me talk about that a lot. From at the point of diagnosis, it's really important to start that conversation so we can help proactively navigate through different insurances, treatment changes over long term. So they did a study about discussions about cost, and this was related to oral prescription costs. 70% of those in the study had copays, yet only 35% had a discussion prior to treatment starting. That's very, very low. So again, we're going to talk about how to find that help. If somebody didn't start that conversation with you, who to go to and who to ask. Before we get started with kind of practical insurance and assistance and disability, when I think about financial toxicity and addressing it and understanding it, I use Maslow's hierarchy of needs as a framework. What Maslow said is if we're not addressing the lowest level of need, which is our food and water and rest and shelter, we can't address higher level needs. Healthcare falls into the green level or safety needs. So if we're not addressing the physiological or basic needs in that purple level, how can somebody access care? So it's a really good lens to think about when we're addressing financial toxicity. Okay, so I usually start when I'm working with someone. The first step is really helping them understand their insurance coverage. generally, like prior to diagnosis, if you're going to your primary care doctor, for your physical and not using your insurance a lot, I had to look initially like what my deductible and out-of-pocket is. This isn't something that we think about every day, but when you're diagnosed and now we're starting treatment, this becomes really important to understand. We have these terms that we don't understand, but it helps us understand what our cost is going to be too, and what we can do to put help in place for those costs. So this comes from OncoLink. They have a lot of great educational resources. So let's start from the top. Our premium is what you pay each month, generally monthly, for your insurance. Deductible is what you pay before your insurance starts to pay. So it might be a $300 deductible or a $5,000 deductible. That is what you'll pay until your insurance starts to kick in. And then we have what's called our max out-of-pocket. That is the most you will pay in your plan year. So you meet your deductible, which is a part of your max out-of-pocket, but say your max out-of-pocket is $7,000 for the year. That is the max you will pay. A copay, what you pay for that individual service. So it could be to see the physician that day or for some type of imaging. We all have different copays. And then coinsurance is a percentage of what you pay towards the bill. So after meeting your deductible, you might have a coinsurance until you meet your out-of-pocket. It varies for in and out of network. Can be different deductibles and out-of-pockets for in and out of network, and also copays vary based on service. So you'll hear me talk a lot about commercial and Medicare and Medicaid. Commercial insurances generally are employer-based plans, plans that you purchase through the marketplace, or otherwise known as Obamacare, or through a private insurance company. And then Medicare, Medicaid, VA, and TRICARE generally fall under what we call government-based insurance. We'll talk a little about loss or change in insurance too. And at the end of the talk, I'm going to share a story of an individual I worked with. We actually worked through all 5 of these insurances because we worked together for 5 years. So even though we met initially and she had employer-based coverage, I helped her navigate through all of these insurances because the financial distress is not a one-time thing, right? Our treatment changes, plans change, life changes. So we might not have an employer-based coverage. Now we're on a marketplace plan. So things constantly change, and we need to continue to look at this long term so we can proactively navigate it. So we're going to get started with different types of insurance, and I will say this is information that is accurate right now. We know there are changes coming with insurance and in the healthcare system, so you may see different information next year, but generally this is accurate for 2025. And we're going to go over an overview of all different insurances and assistance in general, because we could spend a whole session on a deep dive Medicare or Medicaid, but we'll give a little bit of information about each and how to find help to access all of them. So with our employer-based plans, if they are ending because we're no longer working, there's something that may be available called COBRA. And it depends on your organization. So those that are have 20 or more employees in the prior year have to offer COBRA. It's a continuation of your healthcare coverage through work, and it's for employees and family members. And it can last up to 18 months, and in some cases 36, depending on the qualifying event. Important things to know about COBRA is you have a 60-day election period, so if you don't elect that first day that you lost coverage, you do have a 60-day election period. It can go back, and that the payment is due 45 days after signing up for COBRA. And this information, there's helpful information on the Department of Labor website on COBRA. If someone loses their employer-based coverage and they're not going to elect COBRA, the marketplace may be an option for them. And so the marketplace, or we call ACA plans, or the Affordable Care Act, or otherwise known as Obamacare, each state, they could have the national website that you would go to, and some states have their own state-run website. So I'm from Pennsylvania. We have what's called Penny for Pennsylvania. But if you go to healthcare.gov, it will direct you to the website that you need to go to and the phone number for your particular state if they run their own website. The marketplace is income-based. There can be subsidies and cost-sharing reductions available to you based on income and household size. Here's the phone number for the marketplace. What's really important when navigating this is working with someone at your treatment center, because you want to make sure that the plan that you're picking is in network for your provider. And also working with someone at your treatment center, they know what your treatment plan is, what assistance might be available. So it's really important to, partner with someone there. And also all these considerations, the deductible, what the coinsurance is, what the max out-of-pocket is, what the co-pays are going to be, and your monthly premiums. So all things when you're comparing plans to really consider. Again, I talked about confirming providers, and you probably heard of open enrollment. We're headed into that season now. It opens, and then generally it ends December 15th. If you want your plan to start January 1st, can go to January 15th. Some states, it can go a little longer. There are special enrollment periods. This is key to know. So throughout other parts of the year, if you lost your coverage, this could be an option for you because it opened up a special enrollment period. You had a life event, a loss of coverage that made this available to you. Another kind of tip is if you go to the marketplace and you're actually qualified for Medicaid, the marketplace will direct you to Medicaid. They're kind of in sync, those two systems. So if you apply for Medicaid and you don't qualify, they will say you might be able to get a plan through the marketplace. So vice versa there. Talk a little bit about Medicaid, another government insurance that I mentioned. You can apply for Medicaid at any time. It provides you with full coverage. It can become a primary or secondary coverage. There are many different Medicaid programs. So there's primarily like healthcare coverage, but there's other Medicaid programs available in the state to help with different things. You can apply online, in person, at your local Department of Human Services, by phone, or by mail. You can find a paper application online and mail that in. And generally, if you get approved, then what will happen is they'll ask you to pick a plan, so a managed care plan that manages your Medicaid. And I know this happens in Pennsylvania, so I'll just put this out here. It might in other states. I always, when I know that I'm working with someone who is approved for Medicaid, I give them the number to call to pick the plan, because what I found is they pick the plan for the person, and it could be one that your provider doesn't take. So we try to be very proactive with that when picking the plan. And another thing I like to mention is that when an individual had Medicaid, but now they're eligible for Medicare, that income qualification to keep Medicaid lowers. in expansion states that have expanded Medicaid. So when I have someone who I'm working with that has Medicaid and now they're eligible for Medicare, we're always reassessing at that point to make sure they're going to keep that Medicaid, and if not, then help them find another plan to be a secondary. Okay, Medicare. Generally, it's available to those who are 65 or have been on disability after 2 years. I like to mention the importance of this window that we have. So when someone becomes eligible for Medicare, there's a window of 6 months that you have one time to get a Medigap or supplemental plan if that's what you'd like. So I like people to know about that, but you've probably heard about all the letters associated with Medicare. So there's 4 different parts. Hospital, which is part A, B, which is medical or outpatient care, C, which is actually our Medicare Advantage plan, so that bundles A, B, and sometimes D, and then part D is our prescription drug coverage. It's important when transitioning to Medicare to get help with that because it can be very overwhelming, very confusing. You're probably getting calls and information in the mail from many different insurance companies. So nationally, you can go to what's called the SHIP program. So I have it here on the screen. So if you go to shiphelp.org or call that number, they will help get you to a person in your state, then down to actually your county that can help you navigate Medicare. They are unbiased Medicare counselors. They're highly trained, they're volunteers, so they're not associated with any one plan, like somebody, just working with that plan. And they're gonna give you a whole overview of Medicare and a great education so you understand all the ways that you can set it up. Medicare, of course, has different enrollment periods. We're going to be coming up on open enrollment for Medicare. I often work with people to look at their plan, make changes during this time. So it's an important time to remember. And then there are different other enrollment periods as well. Okay, so there were some pretty big changes for Medicare Part D for 2025 that were a result of the Inflation Reduction Act. And I like to highlight this and how to help with this because it's been a big thing this year. So what happened was the Inflation Reduction Act brought us a total cap on Medicare Part D. Now this is just for D with prescription coverage. So the annual cap on Medicare Part D went down to $2,000 for the year. Prior to that, could be very high. You probably heard of things like the donut hole and catastrophic coverage. That all went away. So good news, it went down to $2,000. However, $2,000 is still quite a bit to pay for this would be oral prescriptions. With that, they also started what's called the Medicare Prescription Payment Plan, or M3P. So they lowered the total out of pocket to $2,000, and then they offered a way to make a payment plan across the year, if you'd like, depending on when you opt in. So you can smooth payments out over the year. What changes is you're actually making those payments to your insurance company, whoever your Part D plan is, not to the pharmacy, so not at point of sale. And it is something you have to opt into. You can also opt in and opt out at any time. So how would you know if this is something that would be a benefit to you? Right on the Medicare website, you can plug in your medications, what your plan is, and it will tell you if this payment plan is a benefit. which is an excellent option, but I have a hand up because I like to kind of stop there. We're going to proceed with the next slides because there's always a couple of programs I look at with individuals that I work with before they go to the payment plan. Is there a way that we can reduce that $2,000 with other resources before having to opt in? And so probably one of the most important programs, if you have Medicare Part D, I meet and assess everyone I'm working with for this program. This is not a new program, it's always been around. It's called Extra Help, or the low income subsidy. What this does is it brings your prescription drug costs for 2025, it's roughly about $5 for generics, and for brand name drugs around $12. So say you have a high cost oral medication, you go to the specialty pharmacy, calls you and says it's going to be $2,000. Always see if you're eligible for this program. It's a federal program. It's run through Social Security. You can apply over the phone, or there's a really quick application online. I did put the annual income guidelines for individuals and married couples here, and this will probably change a little bit next year. These are the 2025 numbers, but this is the first thing I look at if somebody qualifies for this. That it helps, pay. You're not going to be paying the $2,000. We don't have to look at other assistance. If you don't qualify for Extra Help, your state may have a pharmaceutical assistance program available. You can go right on the Medicare website, plug in your state, and they'll tell you if you do. In Pennsylvania, we have what's called PACE and PACEnet. They often allow for a higher income level than Extra Help does. So this would be kind of like my next step. If someone doesn't qualify for Extra Help, we're going to look to see if they qualify for the state program. And then finally, another option before checking into the payment plan would be, are there other resources and financial assistance programs available to me? So this is not only for oral medications, but now we're going to expand this to infusion, injection as well. So there's something called copay cards. We look at if somebody has commercial insurance. They are run through the manufacturers of that medication. And again, that could be available for some medications. There's also outside charitable foundations. And generally, if someone has Medicare, I'm going to that first as another option for assistance. They also can help those with commercial plans as well. And they're based on diagnosis. So that's kind of where you start. And then they are also based on income. So we would be putting that in the application as well. So if these two aren't available, or if someone is uninsured, we then look for patient assistance programs, which are also through the manufacturer, otherwise known as free drug programs. It's also really important to mention, if any of those assistance programs aren't available, and actually if they are, if you're getting copay assistance for your treatment, but you have other costs, right? Like bills for scans and labs and doctor's appointments and maybe hospitalizations. It's really good to see if your hospital or healthcare system has what's called hospital financial assistance, sometimes referred to charity care. This is specific to that institution. It's an internal program, and they run them a little different. But again, I'm referring a lot of people to internal financial assistance as well as using those other resources, because it can help with all the other services at that center. Each hospital has their own program. The application, I notice, varies from hospital to hospital. The income guidelines could be a little different, and their policies are a little bit different. It can be both for uninsured and underinsured, so if you have high out-of-pocket costs. And sometimes, depending on the hospital, applying for Medicaid is a part of the process, because they kind of like to rule that out, because if you're eligible for Medicaid, that would cover the bill, but otherwise, then you would be eligible for their program. And this is often found in departments at the hospital that are called either financial counseling or patient financial services. I wanted to talk and spend a little time on the cost of clinical trials. So when we're talking about financial toxicity and addressing costs, we want to look at all costs. Like we talked about treatment costs, we talked about co-pays and costs of like scans and labs and hospitalization. Sometimes if you're enrolling in a clinical trial, there are costs associated with that. And they're generally broken up into 3 categories. When you are being educated on the clinical trial and enrolling in the clinical trial, they should be going over like what costs are covered as a part of that. It's a great time to ask that question, whether it's like a clinical trial nurse or clinical trial educator that you're meeting with. So there are the research costs. So those are what it might be the cost of the treatment or any additional services that are involved with the research. And that should be covered by the clinical trial. Then there are what's called patient or routine costs. And those are generally the costs that you would have whether you enrolled in the clinical trial or not. So your current treatment, follow up with physicians, and those are ongoing costs that are going to go through your insurance and also costs that you already have. And then there are other costs such as transportation to that clinical trial site, maybe lodging is a need, and sometimes they are a part of the clinical trial you're enrolling in. They often offer stipends or vouchers for hotels. They're all different, but it's a really good question to ask when you're enrolling. So, coverage with clinical trials. So, generally, Medicare, Medicaid, VA, and TRICARE, there's coverage for some of those patient and routine costs. Navigating insurance through a commercial plan, you'll want to, find out what is covered and what isn't with that plan and what the process is. Is there a prior authorization needed? And work with that team. Also, calling your insurance company can be helpful. As we're kind of talking about all costs that you could encounter, you might get outside bills from what we refer to as molecular testing or biomarker testing, and your doctor at your treatment center might have ordered it. However, it went to an outside entity or organization, and you get this bill. I often get calls, and the person's like, I got this bill from this company, and I think it's the test that the doctor ordered. They can be very large bills, especially if there isn't coverage for that test. They have very robust financial assistance programs built into those companies. So it can be a shocking bill, but good to know that you can call that company and generally apply for their financial assistance program. So I also want to talk about navigating medical bills. This also adds to the financial distress and toxicity that someone faces. Sometimes you're getting duplicates of the same bill and they start to pile up. I've had people come, it's so overwhelming that I said, throw them all in a bag and bring them to me. We will sort through these and understand what are duplicates, if assistance has been applied, but just some kind of tips to manage this, because especially in the beginning, you're you have a lot of appointments and a lot of things on your plate, and this can become very overwhelming. So you'll get what's called an EOB, or explanation of benefits, and even though it says right at the top, this is not a bill, it is scary because it shows you the amount that the treatment center billed the insurance company and what your potential costs could be. They're very good to keep on hand, though, even though they're very scary to look at, because you can match them up when you ultimately get the bill from the hospital or treatment center. With bills, a couple of tips. Confirming the accuracy of them. So look, and if they didn't send you one that had everything detailed, ask for that, because I had one situation a few months ago where someone with a similar name was on the person's bill that I was working with. So we called billing. It was a complete mistake. We got that removed. You also can show you the differences in the different services you're getting, because sometimes they group that all together on one bill: a CAT scan, lab, an office visit copay. So just check for duplicates and accuracy. And then if you did apply for some type of assistance, say it's the hospital, my goodness. Wow. All right, so I just got my time warning. I do want to talk a little bit and show you this one thing for Social Security. If you are applying for Social Security disability, this checklist can be very helpful to help you prepare for your application. I refer anyone that I'm working with to this checklist. Okay, so I talked about how all costs and how all copays count. This is a gentleman that I worked with, and just to kind of show you what his needs are and then what I worked on with him and how things change over time. He applied for Social Security through work, eventually Social Security disability, had a loss in coverage. We looked at Medicaid for a while. When he got his Social Security disability, we then went to a marketplace plan, ultimately would be Medicare. As far as in-office treatment, we access copay assistance, then full coverage through Medicare. For all those other costs that I talked about, like copays and scans and physical therapy and all different services, we applied for hospital financial assistance. There are other costs beyond what a financial navigator or financial advocate helps with. So I often partner with my social worker because we need to consider all costs: food, transportation, housing, utility bills. So we work together on all of those. And then we're monitoring these needs ongoing. I mentioned some of these costs. Treatment centers are now screening for these costs as well, because we know that sometimes people are making decisions about paying for food or paying for treatment. So these are equally important. Real quick, this is the patient I mentioned in the beginning when I said we're going to talk about insurance changes. I had this conversation about cost of care with her in 2019. We started to build that relationship. I let her know, by doing that, letting her know that this is a common concern, and kind of normalized it for her and let her know that I'm available as we move through different treatments, insurance changes. In 2020, she lost her employment. We looked at COBRA, and only because I found a foundation that could help her with that monthly premium, which can be very high. She was able to continue treatment with no out-of-pocket costs. 2021, we knew COBRA wouldn't be sustainable, so we looked at the marketplace, and although she had to purchase a plan with a very high out-of-pocket, I knew her treatment had a copay card, and we used that in the first week of the year to manage her out-of-pocket costs, and then she had all of her costs covered for the year. I then later in 2022, we identified together that she had no income. She would be eligible for Medicaid. So it's really important to be looking at this proactively and anticipating these different changes and needs, helping keep that financial distress down, because we're doing it very planfully. Like, we knew 3 months ahead that we were going to meet to apply for Medicaid. And then when she eventually became eligible for Medicare, I helped her get that set up so she had full coverage. So I just bring this up because it's not a one-time thing. We know that things are going to change, and we're here to help over time. So how to find help? I have 1 minute. Okay, thank you. If you weren't introduced to a financial navigator or financial advocate, please ask upon diagnosis. It is never too early to ask. In fact, it can help tremendously because we can start to anticipate needs and put those in place, ultimately reducing that stress. If there isn't one at your center, a social worker may have that role too. They may be doing social work role and financial navigation work too. Or if we have both, like we do at my treatment center, we work together looking at all costs. The ABTA has an incredible financial assistance program and a list of other financial assistance programs that you can access. And again, if you don't have a financial navigator, advocate, or social worker at your treatment center, these are some outside national organizations that you can call upon. So ABTA has a care line, and like I mentioned, the financial assistance program. I also do some part-time work for the cancer support community. We have a helpline, Triage Cancer, who is here and has incredible resources. You also can call in and get some help. Both Cancer Support Community and Triage Cancer are those for both benign and malignant brain tumors. So just because the word cancer is in the title, I want you to know that you can call both of those organizations for help. Cancer and Careers is very helpful, and OncoLink, which I referenced earlier. So I think I did it. Yeah. A lot of information. I hope it was helpful. Again, we could dive into one insurance, for an entire hour. But thank you so much. I'll leave this up. Any questions?
If you have a question, please raise your hand.
I'm going to grab water. I don't think it's on.
How about now? Okay,
Perfect.
great. Hi, great talk. Thank you so much for breaking it down. As I'm not a patient, but I find our whole insurance landscape to be very confusing and challenging. So thank you so much. I am a provider and I care a lot about caregivers. So I was wondering if you could speak briefly to FMLA, or, if you're partnered to someone who loses their job and you'd lose your health insurance. Just the caregiver perspective for some of these things.
Yeah, absolutely. I mentioned it very briefly in the beginning. The impact to financial distress impact to caregivers is great as well, often having to take time off of work. And then we didn't really get to this slide, but this is some information about FMLA. So generally, I'm often helping both the individual and the caregiver simultaneously with financial needs and time off of work. The first thing to do is, if you're taking time off of work as a caregiver, to say, what benefits do I have available, and talking to HR, because we all sign up for things in open enrollment at work. I'm like, oh, that sounds good. I'm going to get this. And then I forget kind of what I signed up for and what I have available to me. So some people have FMLA available to them. It gives you the guidelines there. It's with organizations that have 50 or more employees, and schools and public organizations. For those that don't have FMLA available to them through their employer, I found sometimes they are working for a smaller company that's flexible, but the FMLA really does give them that protection.